Hi, everyone. I'm Sara. I'm currently a data scientist at HN. I will give a brief introduction on what we do as a company, and then focus on work we do on AI safety and in fairness. So HN is a predictive and preventive healthcare company. We focus on improving patient outcomes and also enhance the efficient allocation of resources. We have supported over 3,000 patients in 2020 and are currently working with ICSs. The company started with the largest EU study on reducing unplanned care in Sweden. And in 2015, our founder moved to the UK, and we ran the largest UK study on unplanned care. From these studies, HN has 3 services that comprise prediction, virtual ward, and population health analytics. So before I kind of introduce how we use AI to reduce unplanned care, it's important to define and characterize the patients that we can make an impact. So we all know that the NHS is struggling. There's too much demand and not enough supply. What's even more interesting is that only a small percentage of the population actually consumes over half of the non-elective bed days in a particular year. So it's not very fairly distributed, and this cohort of patients tend to be older, have multiple chronic conditions, and live in highly deprived areas. And what tends to happen is if these patients are not identified early enough, their condition deteriorates, and it will be too late to act on improving their healthcare and quality of life, and obviously reducing their attendances at the hospital. No one likes to go to the hospital, so it's good for the patients and for the system itself. What's even more interesting is that these group of patients that are going to spend many days in the hospital are highly transient. So from one year to the other, we have an almost entirely new group of patients who are going to be consuming all of this unplanned care. So that shows us that we need some kind of a proactive care model to identify these patients and work to prevent their increased healthcare demand. So this is where HN comes in. This is where our approach of combining AI-guided patient identification with a clinical coaching intervention and continuous evaluation, follow-up, and really quick discharge, we can, let me see if do I have a light? Yeah. We can turn this high curve into something a bit more tolerable. So the goal is to identify patients before they hit their peak of healthcare consumption, and obviously provide the support clinically, emotionally, socially, for them to cope with their condition, etc. So our process model basically starts with developing our automated case finding that involves work using historically collected hospital data or primary care data, whatever we have. We define our local population, and we build the model based on that. Every day, once we deploy our system, the patients are scored, and every prediction, every risk score given by the AI is then screened by our clinical coaches to determine if the patient is suitable for the program or not. As you might know, a lot of data is lost in unstructured text. So the data that comes in the model is of good quality, but might not indicate that a patient, for example, is in palliative care or has a mental health condition. So just a little bit on the clinical coaching. The clinical coaching is a telephone-based kind of coaching. Our clinical coaches are usually nurses. They do more than just health education. They really motivate the patient and try to make the patient confident that they understand their condition, they understand where they can go and get help, and ultimately not be dependent of a hospital visit. All of this has been proven with our randomized control trial. We've seen a reducing avoidable care consumption. So this would be on bed days and also A&E attendances. And moreover, and I think more important for the patient itself, is their improvement in patient-reported outcomes. The typical patient, as I mentioned before, those high-cost, high-need patients, they tend to be older, living alone, have low self-reported quality of life, and low engagement in self-care, probably not a great relationship with their GP practice, or a lack of understanding of what services are available to them in their local community. These patients have, as I said, multiple chronic conditions. The most common ones are shown over there: COPD, frailty, anxiety, and depression. So this next section, I'll speak a little bit about the work we've been doing on fairness and also on AI safety in partnership with NHS Digital. I'll start with some of the context when it came to participating in this review of the AMLAs, which I believe Shakir might introduce the conversation later on. We've participated as a case study, so our job was to review AMLAs as of a manufacturer's perspective. We are lucky enough that we are both the manufacturer and the deployment company, so we kind of went stage by stage and review any gaps that we envisage with our experience of deploying these kinds of softwares in the NHS. So I'll go section by section and kind of highlight some of the things we thought were important. The first one on data. We use routinely collected hospital data or primary care data. we know that real-world data comes with its biases and limitations. So it's really important to understand that this kind of data has these problems, and when building an AI software model, that we take this in consideration. On the model learning, choice of metrics and minimal requirement thresholds, we, in our case, aim to predict 8 out of 10 unplanned care events, and we pay close attention to the false negatives, for example. It's important that no patient is left behind, and so on a monthly basis, we try to review some of the cases and ensure that if it's a problem with the data, that we communicate with the data providers. If it's related to any technical issue, that we also are aware of it. On model verification, one of the things that we highlighted was the fact that we should have an explicit requirement to verify against biases. So health inequalities is a big issue that I'm sure everyone is aware. And if our data is not representative of the local population, how can we fight against that? And there are some of the things that we do in order to control for these issues of biases and poor representation of certain minority groups. And on model deployment, as I said, we also deploy our AI platform onto the hospitals or GP practices. So we have feedback loops where our clinical coaches that review the predictions on a daily basis are embedded onto the next iteration of the model. So if the clinical coaches are telling us that they are receiving really poor candidates for the program, then it's one of the actions that we need to focus on. And then obviously any automated monitoring tools, we receive data daily from the hospitals or the GP practices, so there has to be some control around it. Otherwise, garbage in, garbage out. And most important, and I should have it in the middle, is to include qualified health professionals throughout this whole process. So our AI model approach was built with clinicians, for clinicians, and me as a data scientist with some experience in the healthcare world, I'm not going to make any changes on the model without confiding with someone who is experienced in the ED department, for example. And we started actually looking at fairness prior to doing this exercise. And fairness is very, very much talked in the AI community, and it as I mentioned before, it follows on the this inherent biases that the real world has, and so our focus is that our AI model does not reduce or reduces existing gaps within service provision and health outcomes. So just as a summary on key things we do when we are building and deploying our AI platform is to include key features of the local population, such as deprivation, ethnicity. We have information about these in all our models. Our approach pays attention to patients' characteristics, medical history, care utilization profiles across secondary care and, if available, primary care or community as well. It's this combination of these kind of 3 types of data that allows us to get really good predictions. Ensuring that the model does not discriminate against any protective characteristic. And I didn't mention before, consulting and involving patient groups. It's important that they understand how their data is used by our AI, what AI services or products they can benefit from, and how they define topics such as safety, fairness, and ethics. A lot of comments that, not a lot, but some comments that our clinical coaches get, or when they are approached, is how did you get access to my data? Why am I being contacted? And so it's really important to explain and to educate the population that this is all IG compliant. We are working with the NHS. No data is being sold or anything. I think a lot of work still needs to be done around there. And then, obviously, having a diverse team working together in all stages. I only joined the company 2 years ago. It was kind of a learning process, having worked at the NHS prior, where a lot of my time was spent writing SQL queries to react to what the different departments needed. And for me, it was a breath of fresh air to see a company trying to be proactive and preventative, and I'm hopefully we'll be able to share more of these kinds of approaches within different areas in the NHS. Just a little slide on some of the fairness monitoring that we do. This is some results from our NHS Scotland work, where we are going to deploy our AI platform onto Glasgow City area. This is showing the false negative rate for our model, looking at ethnicity and deprivation. As we can see here, it performs quite well for patients with a white background. It's quite also obvious that it's quite overrepresented. So it is to be expected that some difference in the model performance is going to occur for these patients. But there are things we can do in order to maybe highlight patients that fall into this group. And a lot of it is also due to lack of data. Some of these patients don't have readily access to the hospital, so they will go somewhere else. And the same for deprivation. Glasgow area has some of the most deprived postcodes, and still, and we see that there is some difference between, these groups of patients who are more deprived or less deprived. So just to end my talk, our approach to using AI is really focused on surfacing and supporting unmet needs. We don't want to reproduce or amplify any historical patterns of health inequality and discrimination. Using AI models, we can surface patients that might be at risk of spiraling healthcare demands and also adverse health outcomes. And these are caused by chronic inequalities, gaps in the service, provision, and access. Thank you.